Okay, so hi, and welcome to Your Brain on Hormones. My name is Dr. Kendra Campbell, and I am a psychiatrist, and I'm the founder of Range Psychiatry. And I am here today with my friend and colleague, who is Dr. Corina Fratila. She is a board-certified endocrinologist, and she's the founder and the president of Ideal Endocrinology. So welcome, Dr. Fratila.
Thank you, Dr. Campbell. It's a pleasure to be here.
Thank you so much. So today we're going to be talking about polycystic ovarian syndrome, or PCOS. So as a psychiatrist, I have for many years seen that there is this connection between mental health disorders and symptoms and PCOS. I've seen many patients. I have a lot of females who have had diagnosis of PCOS. And actually, so recently, Dr. Fratila actually helped me to diagnose PCOS in a patient of mine, this young woman who had not previously been diagnosed, but she had a lot of symptoms that suggested to me she may have it. And in fact, when I was actually talking to her about her symptoms, one of the things that came up is I was asking her about her nipple hair. And it turns out that she did have nipple hair. And but she said, why is a psychiatrist asking about my nipple hair? Which is a very valid question. So the answer is because, and we'll talk a little bit more about this, that nipple hair can be a common symptom in women with PCOS. So it turns out, in fact, she did have PCOS. So there is this very, very strong connection between multiple mental health issues and PCOS. And in fact, mental health issues in PCOS tend to actually be very under-recognized and underdiagnosed and undertreated. We know that women that have PCOS actually have 5 times the rate of anxiety. They have 10 times the rate of depression, the women who do not, and they even have 7 times the rate of suicide. So it's a big connection. PCOS has also been connected with bipolar disorder, OCD, somatization, eating disorders, and even schizophrenia. And we also know that children who are born to mothers that have PCOS, they're actually more likely to have ADHD and autism spectrum disorders. So it's a big connection. So Dr. Fratila, can you talk a little bit from the perspective of an endocrinologist about what type of symptoms you see presenting in women that have PCOS?
Yes, thank you for this question, Dr. Campbell. So PCOS is one of my passions. I've been dedicating the past probably 10 years of my life treating and studying PCOS. Or polycystic ovarian syndrome. I would like to start by saying that recently we know that polycystic ovarian syndrome is actually a misnomer because the truth is that there's nothing really intrinsically wrong with the ovaries. The ovaries are just responding to the metabolic constellation, to the metabolic cascade that's happening in the body. So of course, nobody really knows what comes first in terms of, are the genes determining this? Is the environment determining this? Is it the combination of genes and environment? That's probably the best explanation that we have. But what I mean by the metabolic cascade determining the symptoms of PCOS and eventually the name of polycystic ovarian syndrome being changed to what it really is, which is metabolic ovarian syndrome. So what I really mean by that is that by the fact that the body has a genetic difficulty in handling sugar, that's truly one of the possible or one of the best explanations we have so far for the origins of polycystic ovarian syndrome. And I know this seems like a stretch for our current understanding of polycystic ovarian syndrome, but this is some of the most recent research that has come up in recent years. And to answer your question about symptoms, polycystic ovarian syndrome can present with a myriad of symptoms that vary and that can mimic a lot of other conditions. A very common presentation is acne. Irregular menstruation is also very common. um, abnormal hair growth, hair on the chin or hair on the nipples, hair on the midline, hair in various places where hair shouldn't be in a woman. Um, let's see. Of course, the psychiatric symptoms can be just by themselves a presentation, and they can be the thing that bothers, the patient the most. Even though she might have a little bit of acne, her periods might not be completely on time, or she might have a little bit of hair growth. Those things may seem minor at times, but the psychiatric symptoms can be very, very pronounced, and that may be the main reason somebody asks for help. Some other symptoms I have noticed are fatigue. PCOS can present again with just minor acne and minor or fertility issues, minor fertility issues in the beginning. Don't ask me to explain that. And but then once you start digging and once you start really looking into the root of the problem, you find out that the true issue is metabolic, and that's at the root of everything happening.
Yeah, actually, so thank you. The issue, about it being actually primarily a metabolic illness, that's fascinating to me. I you had just actually told me this, a few weeks ago. Before that, that's not what I learned in medical school. I learned, you have it's primarily an, gynecological, it's in the ovaries. That's what I had learned. So I think that's kind of fascinating. And I think a lot of people probably don't know that, including other physicians, I think don't kind of understand that it's kind of a metabolic. And I was actually reading, which I think is interesting, that there is this strong connection, between the mental illnesses, like especially bipolar and schizophrenia. There's a strong connection, and those also are known to have these underlying metabolic issues as well. So there's this question of like, is that kind of like the common thread that's connecting these? I don't know. I don't know the answer to that. I don't think we know, but I think it's really kind of interesting. And so it's also interesting to me that you said that sometimes what you'll even see is that people come in, complaining of like the psychiatric symptoms. Of course, that's, commonly how folks come to me. What I see a lot, this is just, so common, at least from my perspective as a psychiatrist, every single patient I can think of that's had PCOS has told me this, is that their mental health symptoms, so like their anxiety or their depression, or even like symptoms of mania, or other symptoms, their OCD symptoms or things like that, they will tell me, you know what, it's completely correlated to what's going on with my menstrual cycle. They will say, usually, it varies a little bit, and because they have irregular periods, that makes it a little bit hard, because sometimes they don't even know where they are in their cycle because their periods are so irregular. But they will say that usually that at least that kind of week up until they get their menses, that's if they just have overwhelming. They are super anxious. They are super dysphoric. They're irritable. They are angry. They can't sleep. They say, I don't feel like myself. I feel like I'm somebody else. I don't even recognize it. And then many times they'll say that there is some relief. Like when their period finally comes, there's like this relief and the symptoms get milder and they feel a little bit better. So I was wondering, from your perspective as an endocrinologist, do you see that, and does that kind of make sense from your perspective?
Yes, absolutely. Yes. And I love this question, and I think you're going to love the answer because we never got to talk about this before. So part of also the new research and the new facts that we know about PCOS recently is that the progesterone level, which is the hormone that's supposed to go up the second part of the cycle, as soon as the egg is released, the corpus luteum, the part of the egg that is supposed to be left behind in the ovary, starts making progesterone in the hope that the egg is going to be fertilized, and then the progesterone is the hormone that facilitates pregnancy. In PCOS, for some reason, in most women over the age of 35, progesterone level starts decreasing. And this is also a fact based on, environmental toxins and because of environmental toxins and other factors. But in PCOS particularly, the progesterone level is lower than expected, that second part of the cycle. So this impacts women with PCOS two ways. First of all, they have difficulty getting pregnant and staying pregnant because the progesterone is low. So this hormone that's supposed to facilitate pregnancy is low and stays low. So the likelihood of getting pregnant is slightly lower unless you have, a good doctor on board who's going to supplement you with progesterone. And the second way it's going to impact women with PCOS is that their premenstrual syndrome can end up being horrible. So most of my patients, once I diagnose them with PCOS, I start them either on a progesterone cream if they're relatively young and they need a small dose of progesterone. It's really all empirical. There's at this point we don't have good lab data to look at the progesterone. Progesterone is kind of meaningless when we measure it through conventional medicine tests. So it's trial and error. We start with the progesterone cream, start at 25 milligrams a day, then we go up to 50, and then I start capsules 100 all the way to 200 milligrams a day. And the improvement is tremendous. So to answer your question, the reason for the worsening of psychiatric symptoms in polycystic ovarian syndrome sufferers is because the progesterone level tends to be very low. It's not secreted enough. It's not secreted at the same level. And just to give you a very quick analogy, we also know that the men's testosterone level tend to drop after 35. So the progesterone in women tends to drop. It's kind of like the equivalent of testosterone in men. But PCOS sufferers tend to have a much lower progesterone level to start with, even when they're younger than 35.
Interesting. And so does that mean too then when they are approaching menopause that can be worse for them, or what kind of happens then?
Absolutely. And perimenopause can be really difficult for PCOS sufferers. That's a whole new conversation.
Another topic, yeah. And on that topic too, I mean, and that's such a common thing that I see too, by the way, is that there's these different kind of cases that I see. It's like the younger women with the PCOS symptoms coming in with all these symptoms, and then that perimenopausal period is also a very common time where people women end up presenting to psychiatrists because they're just feeling really depressed or feeling really fatigued or all those things. So again, so much of, I think, there's so much of a connection between these two worlds. Like I can't emphasize enough that the brain and hormones, that they're connected. I mean, it's just, it makes sense. And it's just, I think, something that it's very underappreciated. I don't think it's something that, at least in my medical education or, residency education, I don't think I had a single lecture or anything about this topic, to be honest with you. And so I think it's just so important that we kind of like talk about it, because it's a very big deal. And of course, a lot of times the treatments that you may be giving them too may affect their, the psychiatric symptoms, mental health symptoms, and vice versa. Potentially maybe something that I would be doing would be affecting, their endocrine system.
So I want to say two things. One, you're going to be surprised that even in my endocrinology training, we had very little training about women's health. Polycystic ovarian syndrome was very low on the list. And pretty much everything I know, I accomplished through personal research and, through my own interest and in just pursuing what I thought was missing from my education. So yeah, it's something that's not easily available to conventional medicine doctors, for sure. And then the other thing I wanted to say, just because when I mentioned the word progesterone, this might trigger some people to think that I am maybe a proponent of birth control, because progesterone, estrogen, birth control, when you start talking, there's this association. But what I'm talking about is natural micronized progesterone, which is very different than the progesterone that's in birth control pills. One of the typical conventional medicine approaches to treating polycystic ovarian syndrome is giving birth control pills. And again, this is very, very different than the progesterone, micronized progesterone, natural progesterone that I give in my practice. And the analogy that I usually like to make for my patients is that your body is giving you signals, right? You have PCOS, your body is giving you all these signals. You have acne, you have irregular periods, you're anxious, you can get pregnant, whatever. You have hair growing in places where it shouldn't grow. And then you take birth control pills because your doctor recommended, your doctor said all your symptoms will go away. And this is almost like having the lights on the dashboard of your car go off, indicating that there's a problem with the engine. And then you take duct tape, which is the birth control pill, you put it all over the dashboard, and then you go, everything's fine. I mean, I can't see the lights anymore. It's fine. But nobody's actually looked at the engine to figure out what was wrong with the engine. So I'm not a proponent of birth control pills. I'm a big proponent of progesterone in people who really need it. But again, that's a very different story, because progesterone is progestational, meaning it's the complete opposite of birth control.
Yes. Oh, wow. Thank you so much. And thank you so much for clarifying too, the different types of progesterone. And thank you for that analogy, because I think it couldn't be more perfect. And I have found the exact same thing to be true. I mean, I cannot tell you how many women that I have seen. From my perspective, it's the mental health symptoms that I'm concerned about. But I have seen them become profoundly depressed, profoundly anxious, manic, even psychotic, because of hormonal birth control. And almost every time, if a patient actually comes to me, usually one of the first things that we'll do, although it can be challenging because we have to figure it out, is to try to get them off of the hormonal birth control. And just doing that, it takes some time. I'll say, like, they don't get better. Some of them feel a little bit better, but sometimes it can take several months before they kind of feel better. But they do. They start, again, like telling me that they feel more normal and like less depressed and everything. So yeah, I think it's very fascinating connection there as well. So.
Yeah, this reminds me, it's not my own article, but I published an article on my blog a while back about the connection between birth control and depression, and increased rate of suicide. Now we know that birth control is one of these medications that will terribly affect the microbiome.
Mm-hmm.
And then I guess we can have the conversation in another lecture.
Yeah, actually, I think this is a perfect topic that we can have another episode. So I think this is probably a good stopping point for this. So again, Dr. Fratila, thank you so much for coming on for this episode. And I think if possible too, we're going to be talking maybe a little bit more about making the diagnosis of PCOS potentially in the next episode. But thank you so much for coming.
Thank you, Dr. Campbell. It's always a pleasure.
Namaste.